All right. Thank you very much for coming, everyone. This is oral session 8. We have 8 minute 8 talk that we need to finish by 6:15. My name is Oswanto Sukandi. I'm a HPB surgeon at Athena Health Tampa. We'll be doing this with two of my partners, Erin Maynard from OHSU and Professor Maria Uribe from Chile. So we're gonna keep this brief. We're gonna keep it going. We have a discussion for each paper, so we'll do this. I'm gonna start with the first paper. It is predicting post hepatectomy liver failure and post-operative complications after major hepatectomy. Paper will be presented by Jane Wang from UCSF and will be discussed by Thomas Sirikela at the end. Thank you.
All right. Good afternoon, everyone. My name is Jane Wang, and I'm one of the general surgery residents at the University of California, San Francisco. I want to thank everybody for the opportunity to share our work titled Predicting Post-Hepatectomy Liver Failure and Post-Operative Complications After Major Hepatectomy. We have no disclosures. So starting with background, post-hepatectomy liver failure, or PHLF, is a well-known and serious complication after major hepatectomy, with a mortality rate in the literature reported up to 56%. However, PHLF in isolation does not comprehensively capture a patient's clinical course, as patients may experience serious complications unrelated to liver function. Adding the Comprehensive Complication Index, or CCI, as an additional metric can potentially address this issue, as it provides a more global view of the patient's clinical course. Importantly, no studies to date have attempted to predict both PHLF and CCI in patients undergoing major hepatectomy. Thus, our objective was to develop and validate prognostic models to predict clinically significant PHLF and serious complications using both preoperative and intraoperative variables. We defined clinically significant PHLF using the International Study Group of Liver Surgery, or ISGLS, criteria, which defines PHLF as elevation in INR and concurrent hyperbilirubinemia on or after postoperative day 5. We specifically looked at ISGLS grades B and C, since these patients were those who either required non-invasive or invasive intervention. We quantified complications using CCI, which represents an aggregate measure of a patient's postoperative morbidity. It is computed based on a weighted sum of the Clavien-Dindo grade of each complication experienced by the patient. We used a score of greater than 40 to define serious complications based on its use in existing literature, as well as the fact that it corresponds to experiencing at least one organ failure level complication or multiple complications of lower Clavien-Dindo grades. In terms of study design, this was a retrospective study that utilized a multi-center international cohort from 12 centers in North America, Asia, and Europe. Our cohort consisted of adult patients who underwent major hepatectomy at a participating institution from 2010 to 2020. Of note, we defined major hepatectomy as the resection of greater than or equal to 3 segments or greater than or equal to 2 segments in the context of cirrhosis. We excluded patients who underwent preoperative portal vein embolization or 2-stage hepatectomies. And finally, we collected data on relevant preoperative and intraoperative variables. In terms of the analysis, after randomly splitting the data into training and testing sets in a 70-30 ratio, we performed single and multiple imputation in the training and testing datasets respectively to handle missing data. Next, predictive models for both PHLF and CCI greater than 40 were fit using logistic regression with a lasso penalty on the imputed training cohort. Hyperparameters were then tuned using 5-fold cross-validation, and the models were evaluated on the testing dataset. Both model discrimination and calibration were assessed, and we used the results to create a web-based calculator. So moving on to results, in a complete cohort of 2,192 patients, 8.4% of patients met criteria for clinically significant PHLF. and 7.3% of patients had a CCI of greater than 40. The most common cause of liver impairment was viral hepatitis, and the prevalence of clinical cirrhosis was about 40%. The most commonly reported indication for resection was hepatocellular carcinoma, followed by colorectal liver metastases, and the median number of segments resected was 4. Finally, about 20% of our patients underwent concurrent surgery at the time of major hepatectomy. So moving on to the models, our final multivariable model predicting clinically significant PHLF had 20 variables, as shown on the table on the left. The final model had an AUC of 0.8, with a calibration slope of 0.95 and a calibration in the large of negative 0.09, indicating excellent discrimination and calibration of the model. Our model predicting CCI contained 21 variables, as shown on the table on the left. The final model had an AUC of 0.76 with a calibration slope of 0.88 and a calibration in the large of negative 0.02, indicating acceptable discrimination and calibration of the predictive model. Of note, we also performed a sensitivity analysis using only preoperative variables to predict both PHLF and CCI. This was done to create models that could potentially be used to aid clinical decision-making in the preoperative setting. Notably, these models had comparable performance, with an AUC of 0.78 compared to 0.80 for the model predicting PHLF, and an AUC of 0.71 compared to 0.76 for the model predicting CCI. Finally, we created 2 calculators on the Evidencio platform based on our developed models to offer surgeons a tool that could potentially be used in both the pre and post-operative setting. The option to include or exclude intraoperative variables was included. I want to share a demo of this calculator. Now, while this is playing, I want to mention that these calculators really help to understand the importance of assessing both PHLF and CCI when risk stratifying patients undergoing major hepatectomies. So for example, if one inputs high-risk values such as increased age, increased Charlson comorbidity index, increased ASA score, but inputs normal values for parameters reflecting hepatic functions such as INR, bilirubin, or platelets, the calculated risk is low for PHLF, but high for CCI greater than 40. So assessing PHLF alone would not have adequately captured the post-surgical risk for this patient. Some limitations of the study must be acknowledged. First, the retrospective nature of the study inherently leads to selection bias. Second, given the data were collected from multiple centers from various countries, there were likely differences in patient selection and perioperative management. However, the added benefit of a heterogeneous cohort was the generalizability of our findings. In addition, data regarding complications were collected from the index admission only, as readmission data were not uniformly collected across centers. And finally, because all participating institutions in this study were considered high volume, the calculators may not be applicable to all institutions. In terms of potential clinical uses, our developed models and calculators can serve as resources to direct patient selection and optimization, provide anticipatory guidance in the postoperative period, and allow physicians to have well-informed discussions about operative risks and benefits with their patients. So in conclusion, our internally validated models and risk calculators may aid in prediction of PHLF and CCI greater than 40 for patients undergoing major hepatectomies. What is particularly exciting about this is that it provides us an opportunity to perform a more comprehensive and holistic assessment of a patient's anticipated postoperative course. Next steps will include external validation of our findings. Thank you for your time, and I'm happy to take any questions. These are the QR codes for our calculators.
Very well presented. Do we have any question from the floor? If not, I have one question for you.
Mhm.
How do you determine 70% for the first stage and then the 30% for the test? How do you choose 70 and 30?
Yeah, so I think when you kind of like train and then develop model, you typically have like training and testing sets. Sometimes you can see like a 70-30 split. Sometimes you see an 80-20 split, but we just opted for the 70-30 split. It's pretty standard.
Sounds good. Please.
Hey, Tom Chiricello, excellent presentation and lots of great work put into that. Question I have, about 63% of patients had a Pringle. So the question I have is was Pringle time looked at? Was it found to be relevant, not relevant? It's 3.5% of the vascular reconstruction, so intuitively they're going to have a longer ischemic time. So I was wondering if that played any part.
Yeah, that's an excellent question. So unfortunately, we did have a handful of variables that we thought were clinically significant, but had a high rate of missingness. So we were unfortunately not able to account for those in our analysis and our subsequent model. So certainly that was a limitation of our study. But again, we pretty much assessed Pringle as a binary variable, and unfortunately not with the time.
Do we have the discussion here for this
Oh, that was
paper?
Dr. Yeah.
Sounds good.
Really nicely done. Can you explain why you excluded the patients that had portal vein embolization, especially if they're already considered higher risk for postoperative hepatic failure?
Yeah, no, sorry guys. That's a great question. So we kind of intentionally excluded patients who underwent preoperative portal vein embolization for kind of two reasons. So one is that, after they undergo like preoperative portal vein embolization, their subsequent risk of developing PHLF and possible like complications after may differ from the cohort who didn't. And we didn't have the numbers to like stratify based on that. So we kind of picked one cohort so that wouldn't affect like the outcomes and the predicted risk. Thank you. Oh.
So I think what we were given and the order in the actual thing is a little bit separate, but the slides are in this particular order. So I apologize if your talk is a little out of order. But our next paper is going to be presented by Dr. Cullinan from Washington University in St. Louis, early experience with Restore declined liver transplant for intrahepatic cholangiocarcinoma. It will be followed by a discussion by Dr. Orloff from Oregon Health and Science University.
All right, thanks everyone. We appreciate the opportunity to present our work. We have no disclosures. So unresectable intrahepatic cholangiocarcinomas are in need of new treatment paradigms. As many have heard throughout this conference, immunotherapy, targeted therapies, and hepatic artery infusion pump therapy have resulted in improved response rates for intrahepatic cholangio. Early experiences from other centers, primarily the Methodist and MD Anderson group in Houston, have demonstrated favorable recurrence rates and overall survival in patients transplanted with large unresectable intrahepatic cholangiocarcinomas. However, liver transplantation via standard donors has not been feasible for patients due to their low MELD scores. At our center, we have a concurrent study ongoing, which is a clinical trial looking at declined livers. These are livers that have been offered up nationally through UNOS that were declined. So these livers were then taken and put on a normothermic perfusion pump for clinical viability testing. These livers must clear lactate and have normal arterial and portal venous flow. And then they must have at least two of the following factors. They must normalize the pH with minimal bicarbonate. They have to metabolize glucose, produce bile, and have a perfusate ALT less than 7,000. We also look for homogeneous perfusion of the pump liver. In this study, 16 of 22 livers that were studied, 73% passed viability testing and were transplanted. Some of these into patients with intrahepatic cholangiocarcinoma. So if you're more interested in this, you can read the paper that's coming out in JACS by Dr. Alumba, who's one of our lab residents at WashU. So this is our cholangiocarcinoma transplant protocol, which was adopted primarily from the Methodist group. So patients must have biopsy-proven intrahepatic cholangiocarcinoma. Very importantly, at diagnosis, they undergo extensive testing looking for extrahepatic disease, as that has been shown to lead to early recurrence and death in these people after transplant if it's missed. Patients then undergo neoadjuvant therapy for more than 6 months. This is combined multimodality neoadjuvant therapy, including chemotherapy, liver-directed therapy, some with hepatic artery infusion pumps. So at the conclusion of at least 6 months, patients with progressive disease go on to palliative chemoradiation. Those with resectable disease undergo resection, and those who have stable but still unresectable disease undergo transplant. So in our series, we've transplanted 8 of these patients. 5 of them have what we would consider to be anatomically unresectable disease. These patients were reviewed at our multidisciplinary conference and felt to be unresectable. 2 of these patients had kind of incidentally found smaller intrahepatic cholangiomas in the setting of cirrhosis. And then 1 patient had had a prior left hepatectomy and then developed a recurrence along the resection margin. But he was ineligible for re-resection due to involvement of portal structures. Here you can see kind of the patients are arranged in this table, but you can see kind of multi-modality neoadjuvant therapy, including nearly everyone receiving chemotherapy, many patients receiving local regional therapy, which at our institution is Y90. 3 of the patients had hepatic artery infusion pumps, 2 had undergone SBRT, and 1 had had a surgical ablation, 1 had a surgical resection. As you can see, the majority of the tumors we would consider to be large intrahepatic cholangiocarcinomas, up to 11 centimeters. For those that had genetic data available, which is 6 of them, 3 of them were noted to have favorable or targetable mutations and did receive targeted therapy. So the time from diagnosis to transplant, the median was 18 months with a range of 13 to 22 months. So these patients are, we're selecting the winners from a large group of patients. These are the patients that are able to maintain liver-only disease for a long period of time. So most of them were evaluated about a year, and then we're on the waiting list for about 5 months with a range of kind of 2 to 5 months. And then, as you can see, the MELD at the time of transplant for the vast majority of patients was the median was 7, and the range was really 6 to 8 for all except 1 patient who had a MELD of 24. So these are very challenging transplants, often because of the amount of preoperative or neoadjuvant therapy that patients have received. So 3 of these patients had hepatic artery infusion pumps. So 2 of them were reconstructed with arterial inflow from the splenic artery, and 1 patient was reconstructed off the kind of common hepatic artery celiac origin. Due to involvement of hepatic veins, 2 patients required kind of bicable reconstructions, kind of with an en-bloc cable resection, and some of the kind of relevant postoperative course. 1 patient required, 3 patients required return to the operating room, 1 for delayed closure, 1 for bile leak, and 1 for hematoma washout. On explant pathology, as you can see, all these patients had really good responses to neoadjuvant therapy. So 3 had no residual tumor. 3 more were converted to what would be considered small intrahepatic cholangios under 2 centimeters. And then there was 1 patient who had kind of a residual 3.5 centimeter tumor at the time of transplant. Looking at the overall survival, there were 2 patient deaths. 1 patient really recovered well postoperatively, was discharged home, and died about 1 month, suddenly died 1 month post-op at home. And then another patient recurred early and died at about 11 months. He had a kind of an indeterminate pulmonary nodule that had been stable off chemotherapy. And then about 3 months post-transplant developed a new nodule in his lung that went on to be kind of the ultimate cause of his death. So that's kind of the summary of our cohort thus far. So as you can see, kind of immunotherapy and targeted therapies have led to increased treatment responses in these patients with unresectable intrahepatic cholangiocarcinoma. And then in patients with unresectable disease with no extrahepatic disease, liver transplant has been successful, but there's limited access to these patients due to their low MELD scores. And thus far, our early experience with the RESTORE protocol has led to successful transplantation albeit of very highly selected patients. With that, thank you to the organizers for letting us present our work. I'm happy to take any questions.
This discussion will be opened by Dr. Orloff from OHSU.
Thank you, and nice to meet you, Darren.
Yeah, thank you.
And I'm actually glad it's raining because otherwise this. So I wanted to thank you for a really great presentation and also commend you and the WashU group for doing this novel work and putting it into a prospective trial. I realize it's very hard to randomize small numbers, but just doing a prospective trial, which other centers that are looking at this have not done. And I also wanted to just comment on, I think, we've discussed this in the session about intrahepatic cholangiocarcinoma, that finding homes for livers that are discarded is really important. So your study really looks at, number one, getting patients to transplant that would not be transplantable and have no other option. And number two, for, solving that piece of the puzzle of using discarded organs and finding homes for them. So again, I think that's really important and I appreciate that. And then just had a couple of questions. Did you stratify why these livers were discarded? Were they toxic? Were they brinking on, fibrosis due to Hep C, but not? I realized I looked up the trial so that you excluded fibrotic Hep C patients or other reasons for fibrosis. Were they traumatic livers that nobody used? So I think that would be important because it'd be important to know like which livers worked and which didn't based on why they were discarded. So maybe you have that data and there's not a lot of time probably to present that, but that's one thing. And then I realized that not everybody had biopsies, but do you think that in the future you could actually get information about the responses to targeted therapy? Because then you could standardize things and make it more robust so that you're not doing, some local regional therapy on one, immunotherapy on another, chemotherapy, hepatic artery infusion, so that you could actually standardize your treatment. So that's my second question. And I'm wondering if you think that we could get exceptions with UNOS as a policy, MELD exceptions. And when do you think that's ready for prime time for this group of patients? And finally, I was wondering, in terms of, I know the inclusion criteria was brain dead and DCDs, and I was wondering if you stratified that so that we can also look at that and how the pump helped that. And I think that's it. And I want to thank you for sending me your slides last week.
Yeah.
And congratulations for great work.
Yeah, thank you very much. So I think, so the paper will go into more detail about kind of which livers worked and which livers didn't. I think in the study, about half of them were DCDs. Some of them were late declines. And in the beginning of this was before Organox was clinically available. So kind of late declines would end up on Restore because that was a way that we could use those graphs. So that will go into more of those details. Just kind of the high points of that are two of the patients that were transplanted in that study. There were two kind of early deaths, but they were not related to organ dysfunction. So the ones that passed viability testing were transplantable. And then to your questions regarding, I think the monitoring these patients prospectively is very important. I think we will likely see, kind of like in our studies in the MD Anderson study, where we have data about the genetic alterations. I think we will probably see more FGFR mutants in that group that gets transplanted because they have more available therapies. And that will be something that we'll kind of look at for stratifying. I think in terms of exception points right now, I think Gonzalez's paper is probably the best, and kind of less than 2 centimeter intrahepatics that are incidentally found in cirrhotics. You could make the case for advocating for exception points for those patients. I think for these kind of larger intrahepatic cholangiomas, I don't think we're quite there yet. And so they'll either need some sort of trial like this where you can get a decline organ or potentially living donors, but it's another topic. Dr. Onion.
Darren, nice paper. I just wanted to ask, you were aware that WashU is with it. Well, it's been minimized trial. Systemic. CCI. Where does that fit into this algorithm?
Yeah,
Are these two competing trials?
I,
Yeah.
yeah, no, I think that's a great question. I became aware of that today, or not today, but at this meeting that we were part of that trial. I think, we have felt that, kind of liver transplant for these patients, as well as the colorectal liver metastasis patients, is kind of, the last resort for people who have, kind of made it through multiple therapies. I think we're advocates for the pump for these patients and for the colorectal patients. And it's sort of the patients who, through all of those, kind of maximize their therapy, even if possible, kind of use the pump and, to treat or overtreat the liver. And, if they develop liver failure, then use transplant as a backup, which we've done on a few occasions. And so I think that these are kind of, that trial is almost kind of the run into this trial. So if you make it through that trial with chemotherapy and pump therapy, and at the end of that, you still don't have, evidence of extrahepatic disease, those are the people that are going to kind of, be the winners that end up being eligible for transplant, in my opinion.
Short question, possible? Very short. How many of these patients had a well-differentiated tumor? Because if I understood correctly, Mayo, some Mayo yesterday said that they would only do for well-differentiated tumor, which is only 5 or 10%, and in the poorly differentiated, the outcomes were quite bad.
Yeah, and I need to look back and see exactly what they were. I don't know that offhand. I think in our series and in our thoughts is it's more about biologic, response to therapy than kind of what the histology is, the presentation.
If you look at resected cohorts and if you look at 10-year survivors,
Yeah.
those are almost exclusively well-differentiated.
Yeah. Point.
Okay,
Thank you.
thank you very much. Next paper, impact of machine perfusion preservation on liver discard rates since its implementation in the US. Presenter Dr. Todd Robinson from University of Virginia Health System. The discussant is Dr. William Chapman from Washington University School of Medicine.
Morning or good afternoon, everyone, I should say. Thanks for the opportunity to present. We have no relevant financial disclosures. So the disproportion between the organ demand and the supply has led to increased interest in the use of grafts, which heretofore have been considered suboptimal. With the use of those suboptimal grafts, the risk of morbidity and mortality oftentimes precludes their use, especially in very sick recipients. And the organ discard rates are near 10% at this point. So with that, efforts to reduce such risk by improving the quality of marginal grafts for transplantation is essential, and static cold storage, which has been the standard of care for many, many years, is now it's now being investigated that this is not the optimal way to use grafts, or to preserve grafts, excuse me. So as an overview, there are 3 main types of what I would consider perfusion, 2 with machine and then 1 with normothermic regional. So the hypothermic machine perfusion is ex vivo. It's oxygenated currently, and then you perfuse both the artery and the vein, portal vein, and then you can use that on deceased donors in both the brain dead and circulatory death populations. There's also normothermic machine perfusion, which is also ex vivo oxygenated. Both the artery and the portal vein are cannulated. And also used in DBD and DCD donors. And then in DCD donors only, the normothermic regional perfusion, which is in situ and oxygenated. This is a really busy slide, but it goes over the studies that have been done in hypothermic machine perfusion, which predominantly have been performed in Europe, Italy, the Netherlands, and the Swiss group in Zurich, and then also by Dr. Guerrera here in the United States. This is just as a brief overview, a table that talking about the potential for machine perfusion, both in the safety and feasibility, investigating, the use of pumps, the proportion of early allograft dysfunction and primary non-function, and preventing those. And then prevention of biliary complications, which has previously been described as the Achilles heel of transplant, especially using DCD donors, overcoming prolonged preservation time, and then assessing viability and then therapeutic interventions like defatting the liver, which was discussed at this conference also. In the United States, there's a multi-center study, randomized controlled trial called the OCS Liver Protect, which investigated the impact of normothermic machine perfusion. And they found a lower rate of early allograft dysfunction, a lower rate of ischemia reperfusion on biopsy after reperfusion, and then a lower rate of non-anastomotic ischemic biliary cholangiopathy, and then also a higher rate of DCD liver use. So here's organoxin and transmedics, which are the primary normothermic machine perfusion in the US, and then the HOPE system in Zurich, and the LifePort system here in the United States. So expanded criteria donors, according to OPTN and SRTR database, is a definition that is used primarily for kidneys, but in the SRTR data set, it's used for the livers as well, which I think is an important limitation of this study and also machine perfusion studies in general. They define ECD donors as any brain dead donor greater than 60 years, any donor greater than 50 with either hypertension, creatinine greater than 1.5, or death resulting from a stroke. The definition of liver expanded criteria donor is not well defined in the literature. There's varying definitions, including DCD livers, steatotic livers greater than 30%, prolonged cold ischemia time, typically greater than 12 hours, prolonged warm ischemia time, organ dysfunction at the time of procurement, which is quite nebulous, as well as viral hepatitis, which actually is evolving. And now at our center, especially, we are using hepatitis C and hepatitis B positive donors with good results. So we performed a retrospective review of the UNOS SRTR database, and performed a univariable and multivariable logistic regression model. Significant predictors were identified by univariable analysis, and we included those that were clinically relevant within the model. Our primary objective was to determine the role of machine perfusion on discard rates and its impact on discard rates since its implementation in the United States in 2016. And our secondary objectives were graft and recipient survival in the ECD group. So 54,578 liver grafts were recovered. Of those, 49,493 were transplanted, and discard was a 9.3% rate during the study period of 5,085 livers. Machine perfusion was used in a total of 473, or 0.9% of the grafts during the study period. 454 of the transplanted livers and 19 of the discarded livers. NMP was used in 388 liver grafts, and hypothermic machine perfusion was used in 35. There were 12,459 ECD grafts, which was 22% of the total. And of those, 10,860 were transplanted, 1,599 were within the discarded group. So we found that the discarded livers had a significantly higher age. They were also statistically significant higher percentage of Hispanic population donors that were discarded. And then the weights of the donors, as well as the BMIs of the donors, were higher in the discarded group. And then there was a higher proportion of a heavy alcohol use, hypertension, and history of diabetes, as you can imagine. We found risk factors for organ discards based on the multivariable logistic regression analysis included ethnicity, which was Hispanic ethnicity, and then donor BMI and diabetes history, as well as DCD donors and the history of having a biopsy performed. So the most important predictors were associated with liver discard were DCD liver, macrosteatotic livers greater than 30%, and then a history of having a biopsy performed. On a multivariable analysis, which included only the ECD grafts, we identified that normothermic machine preservation was the only predictor associated with a reduction in liver discard. The 1, 2, and 3 year survivals of both the patient and the graft were comparable in those ECD grafts that were transplanted versus who underwent machine perfusion versus those that did not. So in conclusion, liver discard rate in the US is at an all-time high. The use of machine perfusion represents a safe and feasible way to reduce liver discard, particularly under normothermic conditions, which is the most common use in the United States. However, further study is needed to evaluate the long-term impact and outcome of these innovative technologies. Thank you.
Thank you very much. Dr. Chapman.
Will Chapman, St. Louis. That was a nice overview of a complex, complicated landscape right now. And I think we're kind of just entering the phase of consideration of machine perfusion. You know, the two normothermic devices approved have only been approved within about the last year. Centers across the country are kind of just ramping up. There's no approved hypothermic device. The standards for thinking about which one you use at different points in time are not at all worked out. And then there's a cost, and there's a big variation what that'll be. And we don't have, it's not clear cut whether cost reimbursement, it'll probably apply for Medicare patients, but that's most places only about a third of your liver transplant recipients. So what's going to happen with the other 2/3? Nobody knows. One point I would highlight that you mentioned, the definition of ECD is terrible. We don't really even know how to define what an ECD liver donor is. It's not the same. The variables are not the same of importance as for kidney. So I have a couple of questions for you. What?
Yes, sir.
Oh, one other point I'd mention that we have a big problem with, and maybe you'll have a comment on this. HRSA, that oversees CMS and UNOS, a contractor for organ allocation, is strongly pushing for transplant centers to use more liver grafts, get more patients transplanted. 20% of our transplant list patients die before they get transplanted. But the metrics of grading of results have become increasingly more stringent. So what's going to happen? How are we going to take on more risk with these discarded livers? That's question number one. Number two, how will the allocation for discard organs go? Who's going to get that discard liver, and what patient will this go into? In other words, do you think centers should follow the match run? Thank you.
Thank you. Thank you for your comments and for your questions. As far as how do we, I guess moving forward, how do we address the increased risk that we're taking? I think documenting it appropriately is very important. So if we are going to use, even in general, a steatotic graft, I think a biopsy and reporting that in pathology and reporting that to the OPO and keeping that information so that you can perhaps write exception letters or whatever to HRSA or the other administrative governing bodies is important because, and I know that it's been mentioned at this conference, especially by Dr. Pomfret, we're taking on a lot of risk by transplanting these high-risk patients who potentially, just by virtue of their disease, don't have access to transplantation and don't have access to a high-quality graft, and by nature of their disease have a higher risk of surgical complication and graft failure and graft loss. And so, especially in your cohort of like cholangiocarcinoma patients who've had radiation, their arteries are very difficult to deal with, and that adds another level of complexity that is at times insurmountable. So I think documenting it and keeping records and making sure that we have representation in these bodies that we understand and that we're able to argue, that we're having good outcomes, acceptable outcomes with these high-risk grafts.
How much is the additional cost of this procedure?
It depends on the platform, but generally Transmedics is $75,000-$80,000 for their platform, and then the hypothermic machine perfusion platforms are cheaper but still quite costly, $25,000-$30,000. Normothermic does not cost that much, however.
Okay, last question.
Well, thank you. Great presentation and great work.
Thank you.
I wanted to reiterate, I think actually every single study that involves a machine perfusion needs to do a cost analysis, because these centers that are low volume, they're in centers that are actually not resource. They can't afford to do this. So if we're really going to try to expand the pool of organs for everybody, nationally and globally, I think we have to know about what the costs are, because there's such a discrepancy. So I think I just wanted to make that comment, that I think knowing the cost and then advocating for some way to cover it is really going to be important moving forward.
Agree.
Thank you.
Thank you.
Okay, thank you very much.
We are going to move on to the next paper, titled Margin of the Largest Tumor Predict Post-Surgery Survival of Multi-Tumor Colorectal Liver Metastasis. Presenter is Yi Song. Paper will be discussed by Catherine Pork.
Good afternoon. My name is Yi Song. I am a general surgery resident and I am a research fellow at Memorial Sloan Kettering. Today, I'm going to present the margin of the largest tumor predicts overall survival in multifocal colorectal liver metastasis. I have no disclosure. Resectable colorectal liver metastasis frequently presents with multifocal disease. Conventional definition of surgical margin in these scenarios is the minimal margin of all tumors resected in a single patient. However, we know that there are evidence that larger tumors are typically associated with a wider distribution of micrometastases. And interestingly, in one of the previous studies, Dr. Sasaki and others have demonstrated that it is the margin of the largest tumor that was associated with overall survival instead of the minimal margin, which is the conventional definition of surgical margins. However, this study only included about 100 patients and only R1 resections. So in this study, we aim to explore the various measurements of surgical margin and evaluate their prognostic impact. To this end, we performed a retrospective study of 862 multifocal colorectal liver metastasis resections from 1991 to 2016 after the exclusion of extrahepatic disease, two-stage hepatectomies, and ablative procedures. We split the cohort into a training and validation set in a 70-30 ratio and performed a univariable and multivariable analysis on the training set. And for the purpose of the multivariable analysis, we employ the classification and regression tree model. And finally, we performed an internal cross-validation of our results. This is a clinical pathologic characteristic of the training set, which contained 604 patients with 47 major hepatectomies, and 59% had preoperative chemotherapy. 32% had a pump adjuvant therapy, and 57% had a high clinical risk score. We also looked at the tumor and margin characteristic of the training set. Within the training set, the median tumor number was 2. The diameter of the largest tumor had a median of 3 centimeters. We then looked at the various measurement of surgical margins, and these include the minimal margin, the average, and the maximum margin, and also the margin associated with the largest tumor. And the median of those were 5, 10, 14, and 10 millimeters respectively. This is the univariable analysis performed on the training set. In terms of the tumor's intrinsic characteristics, we found that a high clinical risk score and the diameter of the largest tumor were significantly associated with overall survival. In terms of the various measurement of surgical margin, we found that the minimal margin, which is the conventional definition of surgical margin, was not a predictor of overall survival, nor is the average or the maximum margin. Interestingly, it was the margin associated with the largest tumor that was a predictor of overall survival. This was followed by a multivariable analysis. For the purpose of the multivariable analysis, we employ the classification and regression tree model, or the CART model. Similar to the Cox regression model, the CART model identifies the significant prognosticators of an outcome from a list of candidate variables. It does so by iteratively partitioning a cohort into homogeneous subgroups. We provided the CART model with a list of candidate variables, and these include the margin of the largest tumor, other definitions of margins, the diameter of the largest tumor, and the clinical risk score. This is the result of the CART model. It divided the training set into 4 subgroups from low to high risk. Each of the terminal nodes represent one of the subgroup of the training set, and the number in the terminal nodes represent the number of patients in each subgroups. The splitting nodes represent the significant prognosticators identified by the CART model, which were the diameter of the largest tumor and the margin of the largest tumor. And interestingly, the minimal margin, which is again the conventional use of the surgical margin, was not identified to be a predictor of overall survival. The following lists the detailed criteria of the 4 risk groups. For the low risk group, these are the patients with their largest tumor to be smaller than 2 centimeters, and the margin associated with this largest tumor to be wider than 1.4 millimeters. For low to intermediate risk group, these are patients with their largest tumor to be less than 2 centimeters, but with a margin smaller than 1.4 millimeters. For high intermediate risk groups, these are patients with their largest tumor to be between 2 to 6.9 centimeters. And for the high risk group, these are patients with their largest tumor to be greater than 6.9 centimeters. And again, the predictors of the overall survival were the margin and the diameter of the largest tumor. We stratified the overall survival by the 4 risk groups. So from the low to high risk group, the 5-year overall survival were 88%, 59%, 47%, and 21% respectively. And when we looked at the low risk group versus the low intermediate risk group, we saw that in these patients with their largest tumor to be less than 2 centimeters, achieving a wider margin was associated with an absolute 30% higher 5-year overall survival. This was followed by an internal cross-validation, and for this purpose, we created a Cox regression model using the significant prognosticators that we identified above. And these were the diameter of the largest tumor, the margin of the largest tumor, and the clinical risk score. Upon internal validation, the 3-year overall survival had an AUC of 0.628. The 5-year overall survival had an AUC of 0.594. And the 7-year overall survival had an AUC of 0.530. So in summary, based on the univariable analysis, we demonstrated that the minimal margin of all resected tumors was not significantly associated with overall survival. Instead, it's the margin of the largest tumor that was a predictor of overall survival. And this result was corroborated by the multivariable analysis, which showed that the margin of the largest tumor was a superior prognosticator compared to our conventional definition of surgical margin. I'd like to acknowledge a few limitations of this study. First of all, the Cox regression model was created for the purpose of internal validation, and it was not an overarching prognosticating model. And secondly, without an external validation set, the threshold identified by our CART model for the tumor size and tumor margin should not be interpreted as our recommendation for the optimal surgical margin. With that, I'd like to thank my colleague Ken Sire, Dr. Gonen, and Dr. D'Angelica for their expertise and their advice for the project. I'd like to thank all the faculties in the HPB division of Memorial Sloan Kettering. Thank you for your attention. I'm happy to take any questions.
Well done, well presented. Now, Catherine.
Hi, Catherine Farouk. Thank you. That was a great study. And I think, great work coming out of your group. really important to not only think about how we do surgery, but how we can do it smarter to help patients with their overall survival. Two questions I had just based on your presentation. A good number of patients had neoadjuvant chemotherapy, and I wondered if you looked at any sort of pathological features, namely percent tumor response, because, if you have a large tumor and it has a good response, it might be a little bit different than smaller tumors that didn't respond or even larger ones that did. And secondly, with tumors greater than 6.9 centimeters having such a strong prognostic implication, I'm wondering how your group going forward is looking at that, both treatment-wise and surgical.
Thank you, Dr. Paruk. These are great questions. So for the first question, so first of all, our model was designed to compare the prognostic impact of the traditional definition of surgical margin versus the margin associated with the largest tumor. So for that purpose, we concluded that the margin associated with the largest tumor has a superior prognosticating power. With that said, this model was not designed to be an overarching prognosticating model. And of course, we do recognize that there are additional features that will have prognosticating power, including the pathologic response. And in fact, in one of the follow-up study, we're including that factor into the analysis. And for your second question, the way I interpret the data is when the tumor gets larger, which is a surrogate for the aggressiveness of the tumor, the prognosticating power of the margin kind of diminishes compared to the biology of the tumor. So, however, the prognosticating power of the margin is more pronounced in smaller tumors. So if this result can be validated with an external data set, we'd hope to ultimately advocate that we should start using the margin associated with the largest tumor to be the prognosticator in the situation of multifocal colorectal liver mets.
Will Chapman, St. Louis. I may have missed it, but did you tell us the rate of local recurrence? Because to me, the only way this margin issue would have an impact is if those patients had local recurrence rates that were higher than those that had a less than 1.4 centimeter tumor. So a less than or greater than, unless it's local recurrence, I'm not sure how that would matter. So that's kind of question number one. Question number two, I'm not a statistician, but it seems that the area under the curve when you did your ROC analysis is not very strong. And I don't know what that means about taking away these results.
Yes, those are great questions. So for number one, so we do in this project we did look at the overall survival as in the primary outcome. In terms of the recurrence-free survival, we had it included in the paper but not in the presentation. But we did show that in smaller tumors, achieving a wider margin is associated with the improved a higher 5-year overall survival. In particular, in smaller tumors, when you have a margin that's wider than 1.4 millimeters, you'll have a 5-year overall survival around 88%. If you have a narrower margin, the 5-year overall survival is roughly 30% lower. So in terms of the second question, I admit these are moderate AUC values. One of the reasons is that we did not design this to be an overarching, all-inclusive prognosticating model. So the prognosticating capability is a little limited. That said, this is not with the AUC of around 0.6. We show that this is not a random prognosticating model, and I would argue that some of the validating work of AJCC systems, the AUC is also around 0.6 and 0.7.
Sorry, in the interest of time, if we can make the next question brief.
Thank you, Federico Osejo, Cleveland Clinic. I wonder if you have the chance to correlate this with the tumor mutational profiling. There are papers that suggest that the margin wouldn't be that important depending on that.
Yeah, I recognize that. So, like I said, this paper is designed to compare the conventional definition of margin versus the margin of the largest tumor. So we do recognize there are additional prognosticating markers such as the KRAS or the path response of chemotherapy. So in this work, we did not specifically include that factor, but I do recognize this provide additional prognosticating power. Thank you.
Our next presenter is Dr. Worley from Cleveland Clinic, presenting prospective analysis of circulating tumor DNA in colorectal cancer, liver metastases, a first look. And this will be discussed by Dr. Starlinger from Mayo Clinic. And if we could restart the clock, that would be great. Thanks.
Hello, everyone. My name's Chase. I'm a general surgery resident at the Cleveland Clinic. Thanks for letting me chat today. I'd like to thank Dr. Sejo, Dr. Pita, and the rest of the Cleveland Clinic team for supporting this work. We have no relevant disclosures. So circulating tumor DNA, as we've heard in a couple presentations throughout the conference, is a relatively new but expanding biomarker in the detection of colorectal cancer. It's been pretty well shown to have a very important role in the management of non-metastatic colorectal disease. Notably, the dynamic trial found we can de-escalate adjuvant chemotherapy based on ctDNA positivity. But its role in colorectal liver metastasis is a little bit less clear at the moment. The Galaxy study out of Japan showed that positive ctDNA postoperatively correlates with a worse progression-free and overall survival. But that's kind of thus far been the extent in colorectal liver metastasis. So we had two aims with the study. The first was to establish and demonstrate that it is currently feasible in the United States to implement a ctDNA screening protocol in these patients, which is not something I think to be taken lightly because these tests are expensive. And then to perform an initial assessment of the clinical utility of this test in colorectal liver metastasis patients. So we started getting this test in January of 2022 in a routine basis. So patients, and this is a retrospective analysis of prospectively collected data. So we started obtaining this test routinely in January 2022, which continued up through the routine screening through August for patients included in the study. We use the EMR for retrospective review of demographics, outcomes, and management approaches. And we use the Guardant 360 platform. That's a 83 gene panel. It's a send out test that goes to California, but as we'll find out, as we'll see, it comes back very quickly, which is a very useful part of the platform. So the testing schedule with which this is obtained is very important as people progress through different stages of cancer treatment. In our study, we basically obtained this test at the first visit when they came to our liver tumor clinic after the study was initiated. Patients who got that test preoperatively and then got a surgery subsequently were offered another test postoperatively. And then there are some patients included in our study that go back to about 2020 for tests that were obtained kind of at provider discretion without a routine screening protocol. So 52 patients met inclusion criteria of being treated with curable intent and received subsequent ctDNA testing. 34 of these tests, of the initial tests, were obtained preoperatively, 18 postoperatively, and 9 patients during this, at the time that we submitted this abstract, had received pre and postoperative testing. It's very, very important that no patients in the study paid out of pocket for ctDNA testing, and this actually is true across all of our liver cancer patients. Of any kind, including HCC and cholangio. And the median time to test result was 12 days. So we're able to get genomic, snapshots pretty quickly. So first, we looked at correlation between ctDNA tumor mutational burden and people and pathologic response. And notably, this is cytotoxic therapy. We didn't have enough patients to look at like checkpoint inhibitors, which is kind of where this has previously been looked at the most. Patients who had no response to cytotoxic therapy on surgical pathology tended to have a higher tumor mutational burden on ctDNA as compared to patients who did have a response to cytotoxic therapy tended to have a lower tumor mutational burden. It was not statistically significant, but there may be kind of a clinical signal with that we can investigate with higher rates of higher number of patients. And then microsatellite instability. So patients who had microsatellite instability had a higher tumor mutational burden as compared to those who were MS state. So, similar to previous findings, we found that postoperative positive ctDNA after resection or transplant was predictive of disease-free survival. So 20 patients had postoperative ctDNA after resection, which was 16 patients, or transplant, which was 4. If you were positive postoperatively, you were more likely to recur. And that was statistically significant with a p-value of 0.0419. We had a low number of patients who were ctDNA negative after resection or transplant, but it did, in our small cohort, have 100% sensitivity for postoperative for disease-free survival within our study period, which is 271-day mean follow. So 9 patients had pre and post-operative ctDNA testing or sequential testing. 5 of these patients received resection. Those are who you see on there now, and 4 received transplant. 6 of the 9 patients cleared their ctDNA after resection or transplant. There was no systemic therapy received during this. So the pre-operative testing, surgery, post-operative testing with no other therapies in between. And 2/3 of patients cleared their ctDNA, which was statistically and we hope clinically significant. So these are the patients who had a resection, and then 4 patients had a transplant. 3 of 4 patients who had a transplant cleared their ctDNA. 1 patient remains persistently positive. I'll talk about in a second. So as you can see, this is what I was talking about before. Not all 9 patients were pre-op positive, and post-operatively only 3 of 9. That was significant. And then, so of the 2 patients who got a resection had persistently positive post-operative ctDNA, and their tumor mutation, the mutation profile was essentially equivalent pre and post-operatively. So whatever we did in surgery did not clear the blood, blood evidence of disease in these patients. But interestingly, the 1 patient in transplant who got transplanted for colorectal metastasis had a completely different tumor mutational profile pre and post-operatively, whether that's clonal hematopoiesis of indeterminate potential, or CHIP, or whether that's like mutations from donor blood that were not present in recipient blood. We don't know, but that is kind of something that, as we continue to transplant these patients, albeit at a low rate, we will continue to investigate. So this is a little bit of a demonstration just of the power that Guardant has, although we're not totally sure what to use it for, but these are the highest, most frequently found mutations. In a vertical column here is a single patient, and then on the horizontal columns is a gene. So we are looking at, on the left, all the patients, all 52 patients, and how we can line up their mutations next to each other. And then it's split again by pre-op and post-op. And these mutations commonly identified TP53, APC, KRAS are consistent with kind of what we know to be the mutational landscape. By no means is this definitive, but it does what we're seeing in the blood fits what's been previously reported in tissue and things like that. So, and this is in part related to Dr. Sarlinger sent me a list of questions, and one of the things that he pointed out, which is an amazing criticism, is that this we did not have a great testing screening protocol for these patients at the start of the study. But this is what we've implemented in our current institutional protocol to kind of make sure we're getting it at the same time points in all patients. So at the time of after diagnosing a patient and before they start any sort of neoadjuvant regimen, we obtain a ctDNA, and then they undergo their, along with imaging and CEA, they undergo neoadjuvant therapy, and we get another ctDNA, another CEA level, and repeat imaging so we can correlate them. And then before surgery, we get ctDNA 30 days or less. That way we can get the closest to surgery snapshot of tumor biology. And then 30 to 60 days after surgery, we get another ctDNA. And then we get it in concordance with surveillance imaging. So every 3 to 4 months, we surveil these patients for a while after resection, and we'll get ctDNA at those intervals. So in conclusion, probably the most important takeaway, this is currently feasible in clinical practice, and typically patients are not paying for this test. So we can get this without fear of unduly burdening patients. Postoperative positive ctDNA can indicate an increased likelihood for recurrence, so that's supported by the previous literature. Resection or transplant has the potential to eliminate circulating tumor DNA. So, it's only 9 patients, but 6 of 9 cleared their bloodborne evidence of disease, which we found to be, a pretty exciting finding. we need to standardize our timing of when we obtain these samples. So we have our own institutional protocol, but that's really important to make sure that we're comparing apples to apples when we look at this. And then we did not do this in our study, but we need to clarify kind of the additional utility of circulating tumor DNA compared with known biomarkers like CEA and like known tumor factors like histologic differentiation and KRAS on explanted tissue. So thanks, everybody, and I'll take any questions.
Well, thank you for sharing this nice, interesting, explorative data with us. I think it's super important to also start at some point and get some information and the clinical utility, as you mentioned. You answered one of my questions already. So that's certainly a smart idea, I would say. Path response, you said complete path response, or at least significant path response. How did you quantify this? And did you see a association with the grade of path response, or did you just have little numbers to do this yet?
Too little numbers. So we did actually, when we went back and looked at this, we first of all quantified it by surgical pathologist report. So high, low, no response, which is typically how our surgical pathologists kind of report this. There was so few numbers of people who to compare and to perform any sort of meaningful analysis that we grouped them into yes or no in the did respond or did not respond. But as you say, we should continue to look, because hopefully it will be a kind of a correlative trend where more response has associated changes in ctDNA.
And my second question is more like an open question from your inside perspective. What do you think now in the background of the current literature? What's the unique add-on information, add-on angle that you can add with your current data?
Yeah, so I think the most important takeaway is that ctDNA, we can get it. I think moving forward, we haven't totally established where it sits in the current literature about this as compared to conventional biomarkers. The Galaxy study showed that it was better than CEA at predicting post-op recurrence, which is good. But I think our next step is to advance to de-escalation trials similar to the dynamic study. So this data is not certainly by no means enough to say that, but the ongoing indication that post-operative negative ctDNA is less likely to recur. Hopefully that will kind of launch us into avoiding unnecessary adjuvant therapy in those patients. Obviously, we're kind of not quite there yet, but that's the next step, I hope.
Okay, thank you very much. Next presentation is recurrence after multimodal therapy for colorectal liver metastasis, biology, techniques, reflections. Presenter Matthew Hernandez from City of Hope Cancer Center. Discussant David Brower from University of Minnesota.
Good afternoon. Thank you for all being here. My name is Matthew Hernandez. I'm a fellow at City of Hope, and I'm happy to share our work. We don't have any disclosures that are relevant to this work. Super. Colorectal liver metastasis impact patients greater than 50% of the time with distant disease. Liver resection and ablation are effective modalities to treat this. Hepatic arterial infusion pumps have also been used in the adjuvant setting to mitigate recurrence. So we aim to describe clinical pathologic characteristics of recurrence after resection and ablation, as well as characterize pattern recurrence in patients undergoing resection and ablation with or without a pump, and then to determine long-term outcomes of patients with recurrence as stated above. We hypothesize that recurrence outcomes between patients who underwent resection and ablation would vary in context with or without pump placement. Busy slide, but it's a retrospective cohort review of patients between 2010 and 2021. We stratified patients based on their resection type and then whether or not they received a pump. We excluded patients with non-colorectal liver metastatic disease or who underwent cytoreductive treatments. We collected their clinical, operative, and pathologic data. We looked at the number, size, and genomics of the colorectal liver metastasis. Then we defined recurrence in specific ways. So at 4 weeks from the initial operation, Was there a recurrence again at the ablation site? Could it have happened greater than 4 weeks at the ablation site? Was there a recurrence in the liver de novo, so in non-ablated liver? And was there an extrahepatic recurrence? Then we performed our statistical analyses. There were 184 patients, 124 underwent resection and ablation, 64 underwent resection, ablation, and a pump placement. 87 were female, 97 were male, and 73 patients underwent synchronous colorectal and liver resection. You can see on the right, some patients had diabetes, nearly a third had hypertension, and about a quarter had an elevated BMI. When we look at the two groups, the primary tumor was not considerably different between each operative group, similar for the T stage, their pathologic nodal status, and their preoperative CEA values. We look at their genomic data. Majority of patients had a KRAS mutation, 7 had a BRAF mutation, and 2 were considered microsatellite high. We look at the largest tumor size. They were not considerably different, about 2.5 centimeters between the two groups. The clinical risk score was similar between two groups, so high at about 45% and 48% in those who underwent pump placement. The distance between the patient and the center was lower in those who underwent pump placement compared to those who underwent resection and ablation alone. The presence of extrahepatic disease was more common in those who underwent ablation and resection, predominantly in the lung. And there were 17 patients who had peritoneal disease, predominantly tumors that were budding or growing out of their primary tumor or growing out of the liver. The number of tumors, however, was much higher in those who underwent pump placement. We look at the kind of the operative data or the perioperative data. I think the most relevant one would be is that the majority of patients in both groups underwent minor resections. The R0 status was similar between both groups, around 90%. The operative time was not considerably different. The rates of complication were not considerably different. So recurrence data, this is critical. The local recurrence patterns at 1 month were similar between the two groups. So 5 patients in each had a local recurrence within 1 month of their surgery. Local recurrence at the ablative site outside of a month, those patients less frequent were in the ones who underwent pump therapy and treatment. Intrahepatic recurrences were reduced in those who underwent pump treatment. And then total number of any liver recurrence was reduced in the pump group. Presence of extrahepatic disease recurring was similar between two groups. At the time to recurrence was a little bit prolonged in the ablation group with, the pump group. So how does this translate? Overall, in the entire group or both cohorts, the median overall survival was 83 months. We looked at just the overall survival comparing treatment. The patients who underwent pump resection and ablation had an increased overall survival of 92 versus 67 months. And then when we removed the patients without hepatic or with extrahepatic disease, there was a similar finding. Those who underwent pump treatment had prolonged or an association with prolonged survival at 93 months versus 73 months. The number of ablations, so less than 3, it was associated with a prolonged survival. And in those patients who developed another recurrence after initial treatment, having a surgery or ablation again, prolonged patient survival at 77 versus 67 months. So local recurrence patterns were predominantly within the liver. About 37.5% of patients had this, and this is quite similar to previously reported data. Pooled data overall survival at 5 years around 44.8%. In this group, it was 58% in patients who just underwent resection and ablation. It was longer in those who underwent pump treatment. Several authors have looked at the use of the pump and its association with survival, and even those who underwent treatment for recurrent colorectal medicine, either surgery or ablation, they had around 66 months. In our group, patients were able to get to 77 months. It's a sample size limitation, I think, issue here. It's also respective. There's no major comparison groups in terms of non-operative treatments. This is a prolonged time period where management changes and the influences of multidisciplinary discussions, I think, impact treatment. Also, whether or not the treatment for additional or recurrent disease developed, we didn't really have an influence on that, but we have considerable patient follow-up. So recurrence is common. The time to recurrence was about 35 months. Patients who underwent pump placement had a prolonged survival. Repeat intervention prolonged patient survival, and the median survival for the overall cohort was 83 months. I'm grateful for my mentors for this project, and I'm happy to answer questions.
Brower, University of Minnesota. Dr. Hernandez, congratulations on a great work. Congratulations to your colleagues on pretty excellent results, as well as a pretty modern set here of quite a few patients that have done pretty well in my follow-up. I have one comment and two questions, and we'll just do the questions kind of one at a time. My first comment is just a couple of things missing in this database that I think we need to be careful to include when we're talking about pumps being better than anything else. Is time to treatment. So I didn't see any evidence about tacronymus or synchronous disease here, time for initial diagnosis. I think that would be really critical within a publication if that's research with this. And then the second thing is any adjuvant treatment. So we could presume that the patients that got pumped probably got systemic by the few at least, maybe additional systemic therapy. Then I don't know if you're non-pump got some, which we could compare them. So my first question is about these early recurrences. You guys chose less than 4-week time point. Can you just explain that a little bit more? I think there were 10 total patients, and are these actual disease recurrences, or would you consider these technical failures if they're so soon?
Yeah, so the radiologists have done a lot of work in this, and so I copied how they classify things in terms of recurrence. So yes, I think it is a technical failure. There is a rate of technical failure, even if we look at patients who are getting non-intraoperative ablation. And so our data, I think, echoes what is published.
Yeah, great. And then my last question, and this is a nice global question for anybody interested in doing pumps. Pump is a local therapy, but in your data set was not associated with recurrence-free survival, but was associated with overall survival. What are we missing? If you were to go back in time and rebuild your data set, are you missing variables that are going to help us decide exactly why these better with overall?
I don't think we're missing variables. I think what I know it's 8 minutes, but the patients who had pump had more disease burden in the liver and less extrahepatic disease. So when they do recur, it's more commonly in the liver, and we're able to give them an additional treatment, which will prolong their survival, whether that's another surgery or another ablation. I think being cognizant or just kind of finding it's an issue of finding the right patient and essentially the right disease burden and geometry that we can actually give them additional treatments after having undergone their initial resection and pump placement and treatment.
Yeah, so and I'll follow that up with just one last comment about this. When we look at extrahepatic disease recurrences being grouped after putting the pump, it's a bit of a misnomer because we don't put in pumps patients who already have extrahepatic disease. So the availability of a patient without a pump to develop extrahepatic disease is very different. And then you actually have a data point in here about access to care. And I think we have to be very cognizant of patients getting pumps like every 2 weeks, pump bills. I can be followed up very regularly. And I think that would be a very important thing to look at for overall survival.
Definitely. Appreciate it.
Which were your criteria for ablation? I mean, compared with surgery, how do you select?
How do we select patients who get ablation versus not a pump, or just how do we select patients who get ablation?
Just
period?
in the ablation group.
Yeah, so the way that patients are getting ablation is if there's tumor that is too close to the hilum that can't be resected and leaving a functional liver remnant that is appropriate, those patients will get an ablation in that area. But any disease that can be resected and leave an adequate remnant, that's the main goal.
And the size of the tumor?
About 2 centimeters. Okay.
Thank you very much. Thank you. Excellent. Thank you. We are moving on to the last, but obviously not the least. Simultaneous split liver kidney transplantation, a national and single center experience report. Paper will be presented by Radhika Rastogi from University of Virginia. And our discussant is Victoria Ardiles from Hospital Italiano di Buenos Aires. Thank you.
Thank you for the opportunity to present our work. We have no disclosures. So end-stage liver disease and end-stage kidney disease remain diseases for which definitive and sometimes only treatment remains transplantation. Within liver transplantation, there has been the advent of split liver transplantation with allocation of an extended right graft to an adult and a lateral left segment to children or small adults. However, there remains concerns regarding the complexity of split liver transplantation. With increasingly comorbid end-stage liver disease with end-stage kidney disease, the consideration of split liver transplants with combined simultaneous kidney transplantation arises, but adds another dimension to an already complex surgery. When considering simultaneous split liver and kidney transplantation, the consideration of increased technical complications, such as small hepatic artery size and potential biliary and venous defects that might be reconstructed prior to transplant, must be weighed against potential benefits in both increase in the donor pool by adding more usable organs by splitting, as well as increase in graft quality, as only inherently optimal livers are split and thus come with quality kidneys from relatively young, healthy donors. Nevertheless, the combination of a split liver transplant with a simultaneous kidney transplant remains incredibly uncommon. Our study sought to investigate in adult simultaneous split liver and kidney transplants within national UNOS data, as well as within a single institution to look at both prevalence and overall outcomes of these operations. We utilized UNOS standard transplant analysis and research files to select for simultaneous split liver and kidney transplants in adults from 2011 to April 2022 over a 10-year period, finding a total of 76 total patients. We then performed a descriptive analysis of the donor and recipient demographics, post-operative outcomes and causes that led to graft failure, as well as 1, 3, and 5-year liver graft and patient survival. Within our institution, we reviewed all adult simultaneous liver and kidney transplants from 2019 to 2021, which is from when our institution started doing this operation in this iteration, and performed a chart review looking at patient demographics and preclinical details, operative details, post-operative outcomes, and patient and graft survival within this 2-year period. So when we're looking at our national UNOS data, donors tended to be young, male, and predominantly had a normal BMI, making them optimal donors with quality, healthy grafts, as those are the ones suitable for splitting. And this led to unintended optimization of a simultaneous kidney graft as well. Recipients were older, usually middle-aged, with normal BMIs and a slight female predominance. Those undergoing split liver and kidney transplants had a wide variety of indications, most commonly NASH, cirrhosis, and alcohol-related cirrhosis, and had an average MELD of around 26. About 72% of those had concurrent ascites, 30% of which was moderate, and 11% did require preoperative TIPS procedure for their disease, with a little over half requiring little over half having prior upper abdominal surgery. When you look at the time course of this, about 174 days were required on the wait list. And then when they had their organ transplanted, the organ underwent an average of 7.1 hours of cold ischemia time. After transplantation, they were usually able to leave the hospital within 11 days, which are all relatively reasonable time points for this kind of operation. However, what is important to note is that split liver kidney transplants in this limited population did have pretty excellent outcomes. Liver graft outcomes had a survival of about 90% at 1 year, which when compared to all deceased donor liver transplants was similar to published OPTN data. Moreover, this survival persisted with 88% survival at both 3 and 5 years, which are both better compared to OPTN published data. Patient survival was similarly equivalent at 1 year, with 94% survival at that time point, and persisting survival outcomes at 3 years of 92% and 5 years of 90%. Again, the latter two of which were better than published OPTN data for all deceased donor livers. These persistent graft and patient survival outcomes are likely a reflection of the increased graft quality. In the UNOS population, 3 grafts did require retransplantation, and the causes of graft failure were small for size syndrome, vascular thrombosis, and primary non-function, all causes that are more common with split liver transplantation. However, the incidence of each of these was 1.3%, which remains minimal and demonstrates that careful technical consideration and evaluation can potentially mitigate these technical concerns. When looking at our single institution, we had 3 simultaneous split liver and kidney transplants in a 2-year period. All patients were again middle-aged in their 50s with 2 female and 1 male patients, similar to the UNOS population, and they were normal and mildly overweight. While MELDs varied, 2 of our patients did have MELDs in their 30s, and 1 had a recent admission just 11 days prior to transplantation from hemorrhagic shock from her bleeding esophageal varices. All did have clinical history of ascites, esophageal varices, and hepatic encephalopathy, reflecting the acuity of these patients as well. All patients did receive an extended right liver lobe that was split in situ and involved segments 1 and 4 through 8, as you can see here in this picture. The graft did undergo an average of 9.4 hours of cold ischemia time and 43 minutes of warm ischemia time, which are acceptable time points given the increased complexity of anastomosis with these split grafts. Simultaneous kidney transplantation was done both via retroperitoneal or intraperitoneal approach, but total operative time for both grafts did average at 10 hours, which remains relatively standard for this kind of operation. Postoperatively, these patients did well. All left the ICU within 2 days and left the hospital on average within 9 days. 1 patient did require reoperation for bleeding, but no active bleeding was identified at that time. And another did develop infection from urosepsis and was treated with antibiotics. However, no patients required postoperative dialysis, and no graft-related complications were noted during this time. There was 100% both kidney and liver graft survival and 100% patient survival at our average follow-up time point of 2.2 years or to date. So overall, our descriptive review demonstrates there's potentially limited technical risk in performing simultaneous split liver and kidney transplants with non-inferior graft and patient survival outcomes in this limited population compared to published data. Moreover, it potentially provides higher quality liver and kidney grafts from younger donors who have livers suitable for splitting, and also allows for further use of split grafts that may otherwise end up being unused. Overall, simultaneous split liver and kidney transplantation is an underutilized procedure with only 76 such cases in a 10-year period, and it is an opportunity to provide quality transplants for patients in need while increasing the organ pool without increasing overall patient risk. Thank you. I'm happy to take any questions.
Hi, I congratulate the author for the paper. I will split my comments in 2 parts. The first one, it's about the topic itself, and the second one is about methodological considerations.
Yes, ma'am.
There is an increasing proportion of patients that requires a combined liver and kidney transplant. And although we are association to major procedures, as you show, the results are very good and even better because the donors that receives the kidney donor is usually better as if the patient is in a kidney list.
Mm-hmm.
In this case, the graph is even better. You have young donors with thin donors.
Yeah.
And I think this is a very original topic, but because there is no data in the literature, but in Argentina, we use it a lot. And I think we use more split than here. Actually, it's surprising to see that only 76 patients in 10 years, it represents around 0.2 of all liver transplant. And why do you think you don't accept more frequently split liver in US for this kind of patients? It's a logistic problem or medical reasons? And regarding the methodological, it's a little bit difficult to make strong conclusions because the data from UNOS scare a lot of variables, and the other 3 cases are case reports. But I think this paper puts the topic in the table, the good results, and the need to use it more. And my last comment is about survival analysis. The transplant setting, it's a perfect example of competitive risk. So we as a transplant surgeon have to move the survival analysis to be analyzed in the context of competitive risk models and not Kaplan-Meier because overestimates graft survival.
No, thank you very much for your comments. So addressing your first question on why we don't do this, it's really interesting to learn that it is very more commonly done in Argentina. I think I'm coming from like a supposition point, but I think the concerns are often when you have already a complex surgery and the technical considerations in split liver transplantation and the comfort levels some people might have in doing that when you already have the second operation to do with extended times, that a lot of people might pass on it or be more hesitant in adding that dimension. And given the lack of published data on the topic, the lack of familiarity with it might be part of the concerns here. So I think what we're trying to do with this study is at least bring it up and bring more awareness to the fact that it's so underutilized and that it should be considered a lot more. Your second question, or regarding the fact that this is a small sample size, and it is agreed, it's only 76 patients in UNOS, and again, only 3 patients in our institution. So it is hard to make definitive conclusions, but having these trends, these tendencies is promising, particularly when we're comparing it at a large point and having the trends, and this is the way we can only move forward. So I definitely agree with that time point. And your third point on survival is fantastic. Actually, we didn't actually perform quantitative analysis because the sample size was so small, but competitive risk, I think, would be the way to go forward in analyzing this. So I think if we get a little bit more data, that is a fantastic point. We should definitely do that more often. Thank you.
One final question for you. So there's certainly a number of patients who qualify for SLK because they have kidney disease and then they have portal hypertension that precludes kidney alone. Their MELD is 22-ish. So I was surprised and impressed that you had 2 patients with MELDs greater than 30 getting split liver and kidney. So can you talk a little bit about your selection criteria for those patients that are getting both organs but split liver?
So in our institution, when we chose them, I think they were just listed both, and both were in a relatively acute situation, but we were just accepting split liver without doing as careful, not as careful selection, but in terms of we weren't pre-selecting only a good candidate. We were doing it in the same criteria that we would with a simultaneous whole liver kidney. And I think that was the way we're approaching that. Thank you.
Thank you. Real nice job.
I appreciate it. Yeah.
Do we have other questions from the floor? All right. Looks like we're running out of time now. So it's 6:15. It has been a wonderful session. Thank you very much for coming, and we'll see you next year. Thank you. How far is Chile from here?
Yes, 8 hours flight.
From Miami
to Santiago.